Hello, everyone, again, and I hope you're all enjoying the conference and your lunch. And today, right now, I am truly honored to introduce Dr. Sandro Galea, our keynote speaker. Those of us working in public health and working across sectors to achieve social and health justice, to address the conditions and factors that impact the public's health, and especially the health of marginalized communities, have a champion in Dr. Galea. As many of us know, he is currently one of the most compelling voices in health equity. Dr. Galea is a physician and an epidemiologist. He's Dean and Robert A. Knox Professor at Boston University School of Public Health. He previously had academic and leadership positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. He has published more than 700 scientific journal articles, 50 chapters, and 13 books, and his research has been featured extensively in current periodicals and newspapers, one this morning as well. His latest book, Healthier: 50 Thoughts on the Foundations of Population Health, was published by Oxford University Press in 2017, and one reviewer urged, quote, "These 50 thoughtful essays should be read by all those committed to making our world a safer and healthier place." And I couldn't agree more. Dr. Galea, you have an audience here of those who are committed to making our world a safer and healthier place, an audience that is a bit sad, mad, and dispirited today, but even more committed, and especially glad that you are here with us. Thanks.
Good afternoon. Thank you for that very kind introduction. I feel like I'm too loud, and you're... No, it's okay? All right. So thank you for having me here. It's really a delight to be here. As my colleagues and friends who are lawyers know, I actually really probably am a frustrated lawyer because I tend to think that what you all do matters more to health than most other things. So when I was invited to be here, I was delighted to accept. So since we're talking over dinner, I am going to do a talk which combines some data, which is my métier, but also some stories. And I am going to make a simple argument. And the argument is that we are not going to be advancing health in this country unless we talk about health and not healthcare. And I'm going to suggest 10 things that we should be talking about instead of healthcare, and that unless we change the public conversation to these 10 things, we shall not succeed in promoting health. That's really the premise of my argument. And having said that, I'm going to plunge right in. Now, you have me here speaking, which means... Where do I point this? Was that me? Let's try again. Let's see for a second. No, I don't think it's me. Are you advancing from the back? Hold on. I see movement. Try now? Yes, it works. Okay, very good. So, since I'm speaking here, you know there is a problem. That's one of the challenges with being a public health professor, that you get asked to speak about problems. One day I'm going to give a happy talk, but that hasn't happened yet. Here's the problem. The problem is very simple. This is death from non-communicable disease in this country across many countries. The United States is in red. What you see is that we are worse than countries like Denmark and Sweden, which we know because every election we have an argument about why we would not want to be Sweden and Denmark. I always wonder about that, like, why wouldn't we? That sounds pretty great. But we actually kill more people from non-communicable disease like countries like Greece and Italy, and they can get anything right, but we are worse than they are. And I could show you this. I can show you this for any number of health indicators. We kill more people on indicators than all our other peer countries. And the good news is we are very consistent at killing more people at all ages. So this is age groups at the bottom. So this is newborns, infants, toddlers, adolescents, etc. The blue bar is the US death, and the red bar is other high-income countries. And what you see is two things. One is this U-shaped curve, which is very typical of any mortality because you die less in your sort of adolescence, early adulthood. But you see how we are higher than all the other countries at every age. So we kill more people at every age group than all our peer countries. Now, most of you, because you're in the health field, know this. And we have a bit of a shrug reaction to this. We're like, yes, we're not so good at health. But it's just how it is. But it shouldn't be like that. And what I would like to remind us all of is, it wasn't always like that. How often have you reflected that this was not always like that? So let me go back just 35 years. Looking around this room, most of us were around 35 years ago, not all of us, but most of us. So look here, in 1980, the red dot is the US, the y-axis is life expectancy. We were in the top half of life expectancy. Over the past 35 years, we have drifted to the very bottom. So insofar as we have terrible health indicators, we have done this to ourselves. We have put ourselves at the very bottom of the heap in health indicators. And as time has passed, we have been surpassed by countries like Singapore and Chile and Costa Rica. These countries are all healthier now than we are. So in the context of American exceptionalism, because this is America, and we like to think that we're special, well, we have always been special on health. Until about the early 90s, we were special, meaning we had more life expectancy than our peer countries, and since about 1990, we have had less. So we've actually been special on both directions. Now, you might say, okay, this is a problem, but this is America, and we can solve problems, and the way we typically solve problems is by throwing money at the problem. Do we throw enough money at this problem? Absolutely we do. So this is spending on health. So all these colorful lines here are all the rational countries of the world. This is us. This is us, the purple line. And what you see is we actually spend at least 33% more than our next closest competitor on health. So what's the bottom line? We have terrible health outcomes, and we spend more than any other country. I challenge you this. What other industry can you think of where we as a country spend far more than everybody else and have worse outcomes? There actually is no other industry. Sometimes I get education. We do not spend more on education. We're like roughly in the middle in education. Sometimes I get the military. Now that's a very difficult one because outcomes are very fuzzy. There really is no other indicator. There's no field where we spend far more and get less. And this is perhaps my favorite graph in the whole world. Now, I'm an epidemiologist, so I love graphs, so you know this must be good. So the way to read this is life expectancy is on the y-axis, and spending is on the x-axis. So what you see is, you see all these gray lines, all these other countries, they spend more, they get more life expectancy. But look at us. We're like falling off the curve because we spend more and we don't get more out of it. For any of you who work in the field of infant development, you know, there's the growth charts for infants, and the kids then fall off the growth chart, and we call them failure to thrive. That's what this looks like. We are failing to thrive. So we spend far more and get far less out of it. That's the problem. So now that sets up my talk, because my presentation now is about what are we doing wrong. But rather than framing it as what we're doing wrong, I would like to tell you what we should be doing. What should we be doing to be doing it right? What are the things that we need to talk about when we talk about health? Number one, we need to talk about health, not healthcare. Now let me start with a story. For those of you who know the blues, this is Blind Willie Johnson. Blind Willie Johnson is a blues man. He was born at the turn of the 20th century in Texas. He was born sighted, but at age 7, his mother threw lye in his face in a domestic violence incident, and he became blind. So he was in the early 20th century Texas. He was poor, black, and blind. He grew up, he learned how to play the guitar, and he made a living busking, which is why we remember some of his songs. Not a very good living, as you might imagine. He got married, he lived in a house, small sort of shack. The house burnt down, but Blind Willie and his wife had no money. So they kept living in the burnt down husk of the house. When he was 40, he developed malaria. His wife took him to hospital, and he was turned away from hospital. And then he died. It's not clear if he was turned away because he was poor, because he was black, because he was blind. So the reason I tell you the story is I want to ask the question, what killed Blind Willie Johnson? Well, what killed him was malaria, right? That's what he died of. Had he taken chloroquine, he would have lived. But when I tell you a story like that is so extreme, every rational person knows that yes, malaria killed him. But if malaria hadn't killed him that day, pneumonia was going to get him the day after. And if pneumonia didn't get him the day after, something else was going to get him the day after. Because what killed blind Willie Johnson wasn't just malaria. It was poverty, it was racism, it was poor access to care, it was homelessness, it was domestic violence. And I think what the story does is it makes it very, very clear that you really have to have your head buried in the sand deeply to think that we can improve health by focusing only on malaria. Because homelessness and domestic violence and racism and poverty are inextricable from health. Who on earth would have their head so deeply buried in the sand to focus only on the malaria? Well, the answer to that question is us. We have our head deeply buried in the sand to focus only on the malaria. So this is a simple slide. The graph on the left shows the drivers of health. Now, this is very difficult to calculate, but broadly speaking, I think this is right. Medicine and healthcare are about 6 to 10%. Genetics about 20%. Physical environment, social environment, another quarter. Healthy behavior is about 40%, and a bunch of other stuff, 15%. That's what causes health. On the right is what we spend our money on. We spend our money all on that 5 to 10%. There is an enormous mismatch between what causes health and what we spend our money on. So yes, we spend a lot of money on health, but we don't spend it on health. We spend it on healthcare. Now, as you heard in the introduction, right now, I have the privilege of living in Massachusetts. And there's a lot of great things about Massachusetts, and some of you are from there. And one of the things about Massachusetts is it sort of thinks of itself as being kind of special, kind of like, kind of cool. So sometimes I show this in Massachusetts and I get this whole thing, well, yes, but it's not true in Massachusetts because we're better than that. Well, this is Massachusetts. So this is change in spending in the past 15 years. And what you see is we have increased our spending in healthcare by 80%, and we have decreased or kept the same our spending in primary secondary education, law and public safety, mental health, public health, higher education, early childhood education, environment, and recreation. That's Massachusetts. Now, I don't know what your state you're from, but you can, I'm sure, do the same thing in your state, and I bet it looks very similar. So when I make this case, what I hope you all can tell right away, right from the beginning, this is why we are spending so much money and getting so little out of it. Because we are not spending our money on generating health. We are spending our money on healthcare. We are spending all our money on curing malaria. And we are ignoring the homelessness, the racism, the poverty, the domestic violence, the poor access to care that are inextricable from someone who is going to die from the malaria. So point one, we need to talk about health, not about healthcare. I sometimes pose to people a fun dinner party challenge. So next time you host a dinner party at your house, here's the challenge. Start a conversation about health and time how long it takes for one of your unsuspecting guests to use the word healthcare interchangeably with health. I promise you it is less than 5 minutes. It happens all the time. Try it out for yourself. It's a fun party trick. Okay, so number one, health, not healthcare. Number two, health emerges over a life lived. We tend to think of health as my health today. And we tend to think of health as a result scrambling to deal with the needs of the patient, and I'm using that word intentionally, as she presents to the physician today. And we forget that health is a product of a lifetime of experiences and inextricable from that lifetime of experiences. And trying to solve health by dealing with the pathology of today, although one has to do that, is willful blindness to the lifetime of experience that has produced health. So I was trying to think of how to present this to you, so I thought I would actually present this to you using this cartoon. So this is a cartoon. I'm not sure you can all read it, but I'm going to just go through it. There are two panels, the left panel and the right panel. So I'm going to go down the panels. So on the left panel, you say, this is Richard. His parents are doing okay. And on the right, this is Paula. Her parents, not so much. Richard's house is warm and dry. His shelves are full of books, and his fridge is full of food. Paula's house is full of people and not much else. It's damp and noisy as she keeps getting sick. Richard's parents will do anything for their baby. It says, good boy, clever. And so will Paula's. That's why they're working 2 jobs. Richard goes to a great school. It's well-resourced. Good kids, his teachers love their job. At Paula's school, the class sizes are large, the school is underfunded, and it looks like her teachers are tired, stretched thin beyond the stress. Back to Richard. So maybe we can see why the expectations are high for Richard. It's like B+. Oh dear, we need you to get better. but might be slightly different than those for Paula. B+, hey, that's not so bad. Back over the years, these little differences adds up. So Richard, parents paying for university. Paula, juggling work at Polytech, still getting in debt. They start to add up and build to something bigger. And on the left it says, you're my friend's son, I have a good opportunity for you. And on the right is, you should be finishing your studies. Don't look after me, Dad, you're sick. And because each little difference sneaks by unnoticed, yep, your loan is approved, congratulations. On the right, look, we can't help you. Maybe try easy finance. Then maybe Richard starts to believe that he deserves to be on top all by himself. And you see the partner in some firm saying, you're Roger's boy, right? I've heard good things about you. Maybe Paula starts to settle, learns to, quote, know her place. You've got the job, but I'm watching you, sweetie. On the left, congratulations, Richard. What is the secret to your success? On the right, Paula serving food. And Richard says, less whinging, more hard work. I'm sick of people asking for handouts. No one ever handed me anything on a plate. Now, let's be clear. Richard worked hard. I have no doubt. I have no doubt that Richard worked hard. This does not obviate that. What it says, though, is that his present success is inextricable from a lifetime of privilege. Now, I'm using extreme cases to make the point. We don't all come from lifetimes of privilege, but by virtue of the fact that we're sitting in this room means that we all embody some privilege. And we tend to forget that over and over and over again. And we see Paula, who is a server here, who, remember, when she got a B+, everybody was ecstatic, by contrast with Richard, that when he got a B+, his parents got him a tutor. And it is that lifetime of experience that ultimately manifests as our health. And when we look at health only as the end product of today, and we ignore this lifetime of experience, we do ourselves a disservice, and we undersell what we should be doing to make our health better. Now, I showed you a cartoon here, but I could spend an hour showing you data that bear out this point. This is a simple dose-response relationship between number of traumatic events you've experienced in your childhood and your likelihood of using cocaine. How many times do you read stories? You deal with people who deal with young people who use cocaine. And we have a national narrative of just say no to drugs from here on down. And the narrative is, well, he could just not do the drugs, right? Yes, he could just not do the drugs, that's correct. But he didn't have much choice on the traumas that he experienced that are directly linked to him doing the drugs. And I'm using that as one example. So health today is the product of a lifetime of lived experience. And when we talk about health, we need to talk about that lifetime of lived experience, because otherwise, we shall not tackle these experiences through the lifetime that shape health. Point 2. Point 3. Power, politics, and money are health. They just are. They are intertwined with, inextricable from, and a core part of what health is. I'll start by going back to the Civil War, the US Civil War, dealing with the country's original sin, slavery. This is a picture from 1863. In 1863, the Civil War resulted, among many other things, in the largest riots in New York City. The riots in New York City were over the Enrollment Act. The Enrollment Act, which is essentially a conscription act, required men, I think I can remember the ages, something up to 40, it's what I remember, to sign up to be part of the Union Army. But there was an escape clause. The escape clause was $300. If you could pay $300, you did not have to sign up for the army. Even then, and the riots were started by poor immigrants, mostly Irish, who were protesting the patent unfairness of that. So this is just to give you a sense of money goes back always to determining our health. This is Arlington National Cemetery. This is where we bury our people who die in armed conflicts. Why am I showing you this? I'm showing you this because since 1968, more people have died in this country due to handguns domestically than have died in all armed conflicts in this country since 1968. More than are buried in all our Arlington cemeteries and the other national cemeteries. And we keep having events like this. This was just about a year ago, where 59 people died, 500 more injured. And we keep struggling to deal with this. Now, many of you are lawyers, so you know this issue much better than I do. But I just want to point out how this issue is an issue that affects our health, and it is inseparable from the influence of money and power. Here's a simple graph to make that point. This is annual expenditures The orange is on gun control measures, the purple is gun rights, and the blue is gun manufacturing. 2012 is Sandy Hook, which was really a turning point in the national conversation on guns. And what you see happen after Sandy Hook, see what happened? This almost tripling of spending on lobbying for gun rights, and an increase as well on gun safety, gun control, but a much, much smaller increase. That is ultimately what's driving the gun conversation in this country. It is simply inaccurate to say that the conversation about gun rights and gun safety in this country is a conversation at the level of values and principles. It is false. It is actually a conversation about a non-level playing field that is tilted by enormous resources put on one side of the debate versus the other. Now, there's guns, which I realize is controversial, but I thought I would toss it out there. Let me tell you a topic which should be as controversial, but it's not, which is subsidies. We spend $170 billion a year subsidizing the production of corn and its various byproducts, which results in the production of calorie-dense, nutrient-poor foods. And this graph simply shows that living in states which benefit more from subsidies, you are more likely to be obese. It is as simple as that. And we accept that. Now, why do we accept it? Well, because it's really deeply linked to the structures of power and money that ultimately shape our health. So point 3, power, money, and politics are health. Point 4, there is no health for the many if we exclude the few. Now, this is an important point because one of the challenges we have in this country is that we clean our conscience about our national poor health by being charitable. And we do this at the level of the individual, and we do this at the level of the corporation and the private sector. And there's more and more being written about this, about how private sector, not infrequently, spends millions to get away with making billions because we spend it on charity. And we as individuals do the same. We say, with the grace of God, I'm doing fine, but let me give her a few hundreds of dollars to help her, because she is the other. The fundamental point is that that is a wrong perspective, that health belongs to all of us. And we need to move beyond seeing health as something that we're doing charitably to others, to recognize that there is no health for all of us if we neglect a few. Now, we can make that argument on moral grounds, but I'm not going to make it on moral grounds. I'm going to make it on epidemiologic grounds. So let's make it on epidemiologic grounds. First of all, we start with this gentleman right here. This is Jeremy Bentham. Jeremy Bentham is the father of utilitarianism, which essentially is the economic science that counts lives. And Jeremy Bentham's, the fundamentals of utilitarianism are like, if you have 1,000 people, as long as you can maximize how many of them you're making better, it doesn't matter if you neglect a few. For those of you who don't know, this is actually Jeremy Bentham himself. He is embalmed, and you can visit him outside of University College London, except for his head, because his head was eaten by moths, and that's a wax part of that. It's true. I think the moths were rebelling against the dismal science. So how do we make the case that the health of the many is linked to the health of the few? Well, why on earth would you care about health systems and the structure of health systems in West Africa? I mean, you might be charitable, right? You might say, well, I care about the health of West Africans, so I'm in support of health systems in West Africa. Or you might recognize that the collapse of health systems in West Africa results in Ebola in New York City and in Texas. That is why the health of the few is inseparable from the health of the many. Here's another example. This is an outbreak of measles in Minnesota, which emerged directly from anti-vaccine efforts targeting new immigrants, targeting new Somali immigrants. And this is actually from a CDC report, the MNWR. I realize you can't read it here, but what you see is actually the Somali immigrants had the lowest rate of immunization. Somali immigrants, lower immunization rates, measles outbreak in the whole population. Here's another example. 10% of all kids who are killed by cars are actually pedestrians killed by an alcohol-impaired driver. So you can say all you want about you driving carefully and about you belting in your children, about the fact that you do not drink and drive. If you're living in the world, 10% of kids who are killed by cars in this country any given day are actually completely innocent bystanders to cars driven by other people. That's what I mean where we cannot separate the health of the many from the health of the few. And one more example. This is influenza. 50,000 people a year have died from the flu since about 2010, and this is largely vaccine preventable if we can vaccinate the many. So point 4, Health of the many and the health of the few are inextricable. Point 5. Health is actually really complicated. I believe our president said that in an aha moment. It does stand as the funniest moment of a very, very sad presidency. Somehow I never thought of that until right now. Anyway, we actually need to have the wisdom and humility to understand health. Now, why do I say this? I say this because, health is one of those things, because we all experience it. We do suffer from the hubris of thinking, well, we know what's good for us. And, we've sort of known what's good for us between the Greeks, between the time of Aristotle till about the middle of the 19th century. What we thought was producing health was the balance of phlegm, yellow bile, brown bile, and blood. That's what this represents. Now, you're chuckling at that. Well, that was thought to explain all sorts of symptoms like fever. And it was thought that the reason that fever was happening is because you had too much blood. That's what resulted in bloodletting as a cure for fever, which of course killed countless people. Now, we may chuckle today, but I want to point out that we thought this was right for 2,000 years. Like 2,000, that's a long time to actually think this nonsense is correct. So how many things do we think about today are right that we are going to look back on 5 years from now, 10 years from now, God forbid, 200 years from now? Can you imagine? Can you stop for a second and think about the things you're doing today that somebody 100 years from now may laugh at, ridicule, or may think that they will not believe why you're doing what you're doing it? And we need to have that humility about health. Now, how does that is relevant here? We go on the CDC website, and you say, what are the leading causes of death? And the CDC website correctly says, leading cause of death are heart disease, cancer, chronic lower respiratory disease, etc. This is our dominant paradigm about how we count deaths. There's nothing wrong with this. I want to be clear. I'm not being critical. I'm just saying this is typically how we count deaths. In a paper that ultimately was informative for like Healthy People 2020, initially was Healthy People 2000, then in 2020, then also from CDC came the analysis that said, well, we can count deaths differently. Instead of counting heart disease and stroke and cancer, we can count tobacco, poor diet, alcohol consumption, and we can think of those as being the causes of death. In a paper that we did about 10 years ago, we then went further upstream. We counted low education, poverty, low social support, area level poverty, income inequality, racial segregation, and said those are the causes of death. And by the way, just to put this in perspective, the number of people in this country who die from low education, about 190,000, is about the same as the number of people who die from acute heart attack. The number of people who die from low social support is about the same as the number of people who die from stroke. Now, is any one of these paradigms righter than the other? I think they're all correct. It is equally correct to say heart disease is the leading cause of death, as it is correct to say that tobacco and poor physical activity is the leading cause of death, as it is equally correct to say low education is the leading cause of death. But how we understand health really matters, because it matters for our investments, it matters for our priorities, and it matters for what we focus on as we try to make populations healthier. Now, the only good news I have about this is that this kind of argument we have been having since we moved beyond the phlegm, bile, and blood way of understanding humors that cause health. These two gentlemen with the rich mustaches, gentleman on the left is Edwin Chadwick, gentleman on the right, William Farr, two of the founding fathers of public health. Edwin Chadwick was a politician. William Farr was just an epidemiologist. William Farr was counting deaths in mid-19th century London, and William Farr said, here are the number of children who are dying of poverty in London. Edwin Chadwick said, and the quote is, I believe something like, children do not die of poverty in civilized London. Chadwick said, what they're dying of is micronutrient deficiency. Was one of them right or wrong? Well, they're both right. It was poverty that led them to not having food, that led to them not having micronutrient deficiency. But why does the argument matter? It matters because if we are willing to accept that it's only micronutrient deficiency, the solution is micronutrient supplements. Well, if we're willing to accept that the cause is poverty, the solution is much deeper, much more structural. So we need to have the humility and wisdom to understand what causes health so that we may actually act on the real causes of health. That's point 5. Point 6. We need to understand health as a public good. Health is not owned by me or by you. Health is for all of us, and we share our health. This is perhaps an abstract point, but increasingly I've come to feel this is the most fundamental point of them all. And given that this is a legal conference, I actually have a lot of hope pinned on you all to help make this argument more strongly, more robustly. This is the definition of a public good from John Maynard Keynes, which is things that do not lend themselves to market production, purchase, and sale. They must be provided for everyone if they are to be provided for anyone, and they must be paid for collectively or they cannot be had at all. Think about that. Think of how far that is from how we think about health. We, of course, purchase and sell health. We do not provide it for everyone, and we not pay for it collectively. And we do that because our conception of health is ultimately about sickness and the individual rather than about these forces that I'm talking about here. So by way of metaphor, this is New York City where I was before I moved to Boston. Central Park is in the middle of New York City. Central Park is not owned by anyone. It's not for purchase or sale. It's collectively owned and operated. But what if there were a mayor of New York City resembling our president who said, this is ridiculous. Why should I pay for the park so you can use it? Let's just divide up the park and we all get our small pieces and I can do with my park everything I want. Now, I think you'd all agree that that sounds absurd, right? And I think you'd all agree that probably the public outcry would be such that that would not happen. So why is it that we allow that to happen about our health? Why is it that things like this happen? This is Flint. Right? The water crisis in Flint is directly a result of the fact that we do not see health as a public good because we are willing to accept making decisions that result ultimately in poisoning of the water because we do not think of it as our collective responsibility to preserve collective health. And to do that, we need to understand health as a public good. Point 7. At the heart of health has to be compassion. Compassion, not empathy and not charity. Empathy and charity say, I feel for you that you are sick. I don't want to be you. Let me give you something to make you better. Compassion says, we want to live in a better world, and it is unacceptable to me that there are any of us who are sicker than they have to be. That the very notion that we count preventable deaths should be unacceptable. If they're preventable, why are we letting them happen? And we, of course, use preventable deaths all the time. It's part of our lingua franca. Compassion means that we refuse to settle for anything but the healthiest world possible. This is from Martin Luther King, who said, true compassion is more than throwing a coin to a beggar. It comes to see that an edifice which produces beggars needs restructuring. That is the world we're living in right now, where we constantly throw coins at beggars. Now, you're saying to me, okay, well, you're exaggerating. I'm not exaggerating. Take a look at Twitter after any mass shooting. This is ultimate cynicism that moves us away from compassion. It's the prayers and thoughts with the victims of yet another shooting that are not backed up by any structural effort to actually deal with the root causes of the mass shooting. This, another example. This is Salome Dancor. Salome Dancor was a nurse in Liberia. Liberia is a country where I've done a little bit of work in. She contracted Ebola. She contracted Ebola and she lived. After she lived from Ebola, she did what must be unthinkable. Imagine this, like you've had Ebola, you've survived, and then you raise your hand and you volunteer to help others with Ebola. Like how extraordinary is that, right? She was working with Doctors Without Borders in the Ebola clinic for the Ebola epidemic in West Africa, which killed about 18,000 people. After the Ebola epidemic was over, Salome Dancor was pregnant with her 4th child. She had preeclampsia. Her husband took her to the hospital where she had been the nurse looking after Ebola victims, and she was turned away from that hospital. Why was she turned away? Because she had had Ebola. Then she died. Now, I raise this, and I want to be very, very clear that I raise this not to say that there is no compassion in Liberia. I think this happens all the time here. I think I'm using extreme examples to make the case that we need to change how we think about health. Now, what are examples to bring this home? Let's bring this home. 1 in 7 children experienced abuse or neglect in the past year. 20 people victims of violence every minute. 1 in 2 women experience sexual violence in their lifetime. 1 in 5 men experience sexual violence in their lifetime. This is the lack of compassion that we live every day. And we are allowing the structural factors, things like segregation, to drive this. We allow political efforts to create racial, spatial segregation, segregation by socioeconomic status that ultimately divides us and others us, that challenges our capacity for compassion. And unless we find compassion within us to say, preventable deaths, preventable disease is not acceptable. It is not acceptable to have 1 in 2 women being victims of sexual violence in their lifetime. Unless we say that's unacceptable, based on a level of compassion, we will not act to improve these forces. Point 8, health should be a means, not an end. Do you really want to think about your health? Not really, right? I don't want to think about my health. I would like just to be healthy. I mean, forget about you, let's talk about your car. I mean, unless you're a car aficionado, that's fine. You just want your car to work, right? You choose a car, you like it, you choose the color, you choose the seats, and then you want to get in it, and you want it to work. And it's sort of a pain in the neck that you have to go in and get maintenance every once in a while. Wouldn't you prefer to just have a car where you don't have to go to maintenance and it just works? Our health should be just like that. Our health should be a means to live a rich, fulfilled life. And that's how we should see it. It should not be an end. And why does this matter? It matters because if you see health only as an end, you get yourself into crazy things like this. This baby could live to be 142 years old. No, it won't. I mean, it's a cute baby, but now you're all chuckling, but that's not crazy, right? Like this is mainstream. The entire biomedical enterprise has gone nuts with this idea that health is the end, and we should be devoting all our energy and our money into making sure we live forever. For those of you who are interested in this particular segment of my presentation, I just published a piece a couple of days ago about this very topic, which I can give you later. So we are spending all our money on this because of this notion that we can live forever. And it is false. This is actually from a recent paper in Science. And what this shows is the relative increment that we can expect to gain in life. And you see it's actually peaking up to about 90. And once you get into late 90s, there's this enormous drop in the increment in life expectancy that we can expect based on the simple notion of the finite nature of biological redundancy, that in the end of the day, our systems break down and we die. And that's okay. There's probably a natural limit to life, about 115 years. Why does this matter? It matters because if we keep spending all our money on trying to live forever, we are never going to spend our money on actually living well and making health a means so you can actually all go about your life and do what you want to do with your life. You know, in all the argument about us living forever, it's lost that 98% of Americans today die before the age 100, 88% of Americans die before the age of 94. That's the present. And I'm telling you, for all our lives in this room until we die, that's not going to change very much. So we should all have the humility to recognize that we're going to die and invest in living healthy so we can die healthy as much as possible. Point 9. None of this will happen unless we value health. None of this will happen unless we demand health. None of this will happen unless we bring about the confluence of political forces to create the structures that generate health. This picture, that's Lyndon Baines Johnson, LBJ. This gentleman here, much more forgotten, is Wilbur Mills. Wilbur Mills was the chair of the Ways and Means Committee. Wilbur Mills was an ardent opponent of Medicare. He, of course, passed Medicare through Ways and Means. Why did he do that? Well, he actually did it after Kennedy's death and after Johnson won an enormous majority. All of a sudden, there was a public wave of support, and Wilbur Mills astonishingly found within himself to become a champion of Medicare. So why am I saying this? I'm saying this because I think we frequently tend to think of our politicians as leading us on values, and that's nonsense. It's not true. Values come from us. Values are defined by us in a society. And if we want to create a healthier world, we must value health. We must create a world where health is valued. I have written a little bit about this, and this is a simple 2x2 table. And all I want you to see is on the y-axis, we have values. On the x-axis, we have the evidence. So over here is we know what works. Over here is we want to do something about it. Here we don't know what works, and here we're not sure what to do about it. So think about this, polio eradication. We know what works, and we're sort of all against polio. It's easy, right? Things get harder. Zika. We don't really know what works, but we're all against Zika. The harms of injection drug use. We know what works. We know that safe injection sites will reduce the social economic costs of, and health costs of injection drug use, but we don't tolerate it. And then, in the bottom left, we get into the unholy mess of guns, where we're not sure what works because we have stifled research on it, and we're very muddled about our values. Why am I showing this? I'm showing you this because I actually think that it is important, if we care about these things, to work on creating the values for health. It is not good enough to just create data. We need to also create value of health, and we need to create a demand for health. Let me ask you this question. Which world would you rather live in? A world where there is an effective treatment for your Alzheimer's disease, or a world where you don't get Alzheimer's to begin with? Who would like to live in the second world? Yeah, everybody. You don't get Alzheimer's. It's horrible, horrible. And I could ask you that about any disease. Do you want to live in a world where we can treat your heart disease, or a world where you don't get heart disease? Do you want to live in a world where we can make sure you don't get arthritis, or a world where we can give you an artificial hip, right? We want to stay healthy. We want to prevent disease. And because that's what we want, and we feel clear about it, and 100% of people always want to prevent disease, that's why we spend only about 4% of our healthcare dollars on prevention. And we consider it acceptable that over the course of the past 30 years, the US has had 70,000 excess deaths from breast cancer because we've underinvested in prevention. Why should this be okay? This is not okay. And it's only okay because we are not demanding health. We're not demanding that we have governance for health. We're not demanding that we have intersectoral effort for health in the private sector and the public sector. And that should be a core animating principle whenever we talk about health. And the last point, number 10, we should be free to choose health. So this country is built on many founding myths, which are terrific. I have a son in high school right now studying US history, so I'm well immersed into the whole sort of American story. And one of the biggest founding myths that this country is based on is that we want to have the freedom to do stuff. We want to be free, damn it. And what we don't talk about anywhere near as much is that we also should want the freedom from stuff. We don't just want freedom to, we want freedom from things being wrought upon us. We want freedom from obesity. This is just a simple map of obesity in the country, which is extraordinarily fat in this country. And when we have made efforts, and I see my old friend and colleague Tom Merrill is here, to limit structural forces that create obesity, this was the soda wars in New York City, they get ridiculed because they're impinging on our freedom to drink as much soda as we want. But it is on us to change the conversation to say, this should be our freedom to be free from the forces that make us fat to begin with. What are those forces? Slightly awkward, I'm presenting this over lunch, but be that as it may. I will not ask for a show of hands. How many of you had a bagel this morning? Bagel 20 years ago used to have 140 calories. Now it has 350 calories. I know. If you've had a muffin, good luck to you. It used to be 270. Now it's 580. Let's not go anywhere near French fries, which were 270. Now they're 610. That is what we should have freedom from. And we should demand that we have freedom from these forces that ultimately are going to make us unhealthy. We should demand that we have a world where you don't have, this is neighborhoods with low income and high rates of obesity. This is New York City. All I want you to see here is the dark pattern is exactly the same. We should demand that we deal with the physical environment, social environments, economic environments that ultimately result in likelihood of poor health. And when I say that, lest you think of me as like a dyed-in-the-wool socialist or communist, which I'm not. I'm really not, actually. I'm quite a fan of consumption. I'm okay with it. But we've done this. We actually know how to do this. One of the biggest triumphs of health in this century is motor vehicle health, right? So this is number of vehicle miles driven, number of deaths from cars. We drive 15 times more, leaving aside the environmental impact as a separate discussion, and we die 15 times less. For every vehicle mile driven, we die 225 times less than we used to 100 years ago. Why is that? Well, because we won the battles about giving us freedom from dying in our cars. We were able to result in seatbelts and airbags and shatterproof glass and lanes on the side of the road. That all gave us freedom from dying in our cars. So let me conclude. I will conclude with one last slide, and then we can open up for questions. So in my household, we only care about one sport, and that sport is soccer, which I know is not the most popular sport in this country, but some of you will have heard of it. So what's the best soccer team in America? Let's get some votes. Sounders. No, in America. Barcelona's not in America. Not yet. We have not yet and next Catalonia. So I have Sounders. What else? Galaxy, DC United. Atlanta United. You're all wrong, except for the person who just spoke up right now. The women's national team is by far the best soccer team in this country. No question. Atlanta United is okay, but they don't stand a chance. So now for those of you who don't know soccer, let me explain how the game is played. It's very simple. There are 11 women on one side, 11 on the other side, and they just try to get the ball to the other side, into a net. That's how it works. And there are 10 players. Those are the women in blue who can only use their feet, hence called football. The other sport is incorrectly named. But there is one person, that's the woman in red, that's Hope Solo, the soccer national team goalie, who is a dodgy character, but a good goalie. And she can use any part of her body to stop the ball. Right? So for those of you who don't play soccer, you might say, as long as the goalie is the best possible goalie in the world, right? She can save every ball, and we will win, right? Theoretically, that is correct. Now, practically, if you watch a soccer game, what you will see Hope Solo do is prowl the area in front of her net, yelling at her teammates. And what is she yelling at her teammates? She is saying, keep the ball away from me. Because every good goalie knows that the net is very big, and if the ball comes to the net too many times, a goal is going to be scored. Now, why am I telling you this? The goalie is medicine, right? At some point or another, we are all going to get sick. And when we're sick, we want the best possible doctor. We want the best possible goalie, right? Like I would like to recover to health and go back to being healthy. The other 10 players are the 10 points that I made today. They are the points that make sure that we have stable housing, that we have gender equity, that we have an economy that makes sure that all citizens have a livable wage. They are efforts to make sure that the health of the few is not marginalized. Those are the other 10 players. And those other 10 players keep the ball upfield. And it's the only way we are going to actually deal with the problem articulated in the beginning and create a healthier country. I'll stop here and we'll take questions. Thank you for having me. Thank you. So there are a couple of mics roving in the audience. So if you just raise your hand, we will get a mic to you.
It's the quietest this group has ever been.
I'll take lack of questions as indicative of extraordinary clarity of my presentation. It's over there in the corner.
Thank you for the excellent presentation. I think it's very much insightful, and I intend to use it as a framework to think about these issues. But I do have a critique, and I want your assessment of it, and I apologize if I'm presenting a straw man version of your argument. But it seems that while, yes, we have some areas, like, for instance, motor vehicle deaths, where everyone agrees that you should have better airbags and a safer car. There's no one who really advocates for a less safe car, or who wants, at least in the consumer environment, a less safe car. But there are people who enjoy drinking, or who enjoy riding motorcycles, or who enjoy doing various activities which have costs. Those deaths are technically preventable. But to prevent all of those deaths, we would have to cut off access to those things which are dangerous, even though they have other benefits. And we've tried that in some areas. We've done that with alcohol in the past, and it didn't really pan out. We've done that with drugs now, and still not really panning out. And I'm curious, how do you assess those deaths which are preventable, and which we can fully get rid of, and then those deaths which perhaps we have to accept them as part of the society? If people want those benefits, they ought to be permitted to make those choices.
Yeah, it's a terrific question. Thank you. I think it is okay for us as a society to say, we so love riding our motorbikes without a helmet that we're willing to have our brains bashed out on a regular basis because of it. I think it's okay for us to say that, to choose that. But in order for us to choose that, we need to be honest with ourselves that we are having a discussion with a level playing field without the distorting influence of special interests whose interest ultimately is in selling a particular product, and that we actually have an informed discussion that is informed by data. And there's one other thing which I didn't have time to actually cut out from my presentation, and that we also apply an equity lens to that. So data are actually quite clear. States with no motorcycle helmet laws result in a widening of socioeconomic gap in motorcycle deaths. And the question is that acceptable? We need to have that conversation and decide if it's acceptable or not. Many public health interventions result in widening of equity gaps. We don't like to admit this. It makes us like, ugh, makes us feel awkward for us to achieve overall goals. And that may be okay, actually. That may be fine. But we should have the honesty to have that conversation, and we need to make sure that that conversation is not distorted by undue influence. I would argue that we do not right now in the public space have those conversations without distortion. So I don't think we're disagreeing, actually. I don't think there's a critique at all. I actually think it's a terrific elaboration what I said. Thank you. There's another mic coming to you over there.
So going to your son's high school civics classes,
Yes.
And what are we protected from? And we'd call that, I'm a lawyer, the Bill of Rights. And we're being protected from government intrusion into our lives. And so we've set up, and we see in our debates as a national community, this polarization of the role of government in our lives, where government is the harm or government is the protector of the common good. And this tension is baked right into our Constitution. And you framed it protecting from unhealthy foods that are forced on us and advertised, and the biggest nutrition in the country. Nutrition education's on the television or now our screens, whatever they are. And this balance of how do we create government for good when we're so polarized, because now I'm worried about being protected from government now too, and I'm a public health, dyed-in-the-wool liberal, or left of liberal probably. And I'm just wondering if you have any thoughts on this, with the role of government and how we protect ourselves from too much government and not enough government when we need to achieve the common good.
Yeah, thank you for the question. My answer to that is actually not that different than the answer to the previous question. I think a mature society can disagree and can navigate the contradictions that are inherent in what you just said. I think these are very good contradictions. I'll use the example that I lived through with the New York soda wars for a second. I had no difficulty with disagreement among rational people about whether that's right or not. But what ultimately swayed the day was not that discussion. It was ultimately money that poured into the argument by people who had a very particular interest in promoting soda to the detriment of health. And that is what ultimately tipped the scale. So this goes back to the question over there. I think we should have the maturity to handle contradictions. The Constitution is full of contradictions, and that's okay. And we should argue them back and forth. But somehow we need to get ourselves to a place where we argue them back and forth from a place where we are clear about what our values are and where those values are respected, rather than in a situation which we're in right now, where we have what I think is fair to characterize as a federal shouting match with which casts heat but no light. There's a hand up right there.
Thank you, Dr. Galea. That was an extraordinary presentation, and an incredibly powerful series of things for all of us to think about, and I appreciate it tremendously. You're at the helm of an august academic institution. Public health, in my view, is inherently a political endeavor. The academy tends to shy away from politics, and I'm wondering if you have anything to say about strategies that can be brought to bear to help support the idea that people who are keepers of data can also express views about what those data say about what policy ought to look like, and can enter the arena and participate in debates that, in my experience, the academy tends to be very reluctant to engage in.
Yeah, thank you. Well, certainly the small corner of the academic world over which I've had stewardship has not shied away from politics. I do not think that academic public health has the luxury of being apolitical and at the same time honestly say that health and politics are inextricable. You can't have it both ways. When you look at the simple 2x2 graph I showed about values and data, I have argued, and feel free to sign up to our newsletters, which if you haven't, and you can see sort of this argument over and over again, that it is the responsibility of the academy to contribute to the argument over values, which I think the two questions, one from my right, one from my left, both really were about the argument about values. And the academy needs to roll up its sleeves and be a part of that. Now, there are challenges to that, right? There are challenges because ultimately, we as a society look to the academy to generate data that can inform the discussion. And we want to be careful that the data generation is not colored by notions that the data is there to serve an advocacy end. We have to be very careful about that. But I think that can be done. And I think one can have a much more engaged academy by simply having the courage to tangle with issues of the moment and issues that have consequence for our health. You know, what I often tell our school community is, if not us, who? Like, who else but the academy has as free a hand to speak? You know, many of you here are in public sector of some sort. And anybody in the academy should recognize that your degrees of freedom are actually fewer than ours. So it is then on us to capitalize on those degrees of freedom, and it is shame on us if we don't. There's time for one more question, I think.
What's your position on heading the ball in youth soccer?
I think sports adapts, and if the evidence is there, I think the evidence is growing that heading the ball in youth soccer probably has deleterious consequences, and I think it'll be perfectly fine to ban heading under 16. And frankly, if the evidence accumulates that heading the ball in general is bad, it should be banned in all of soccer. I'm okay with that. I think sport will adapt. Thank you for having me. It's really a pleasure.